Welcome to the Hospital Medicine Unplugged podcast. Today we're doing a deep dive into something that, well, it can be pretty tricky, maybe even a bit scary when we see it in the hospital. Prinzmetal's variant angina.
It really is. It's a condition that demands a different approach compared to our usual management of acute coronary syndromes.
Exactly. So this deep dive, it's really about synthesizing the current evidence, looking closely at the guidelines, and focusing particularly on, the critical monitoring and the, frankly, counterintuitive medication choices we need to make for these hospitalized patients. It's truly a supply-side crisis.
That's a great way to put it. It's often hiding in plain sight, this vasospastic angina.
Yeah.
And you're right, it forces us to shift our mindset completely away from just thinking about fixed plaques. The danger here is immediate, often electrical. That's precisely why following the diagnostic and monitoring protocols, like those from the ACHA, isn't optional. It's absolutely essential.
Okay, so let's unpack that initial encounter. A patient comes in, symptoms are suggestive, maybe chest pain at rest, that kind of thing. What's the immediate guideline-driven evaluation look like? What are we trying to achieve right away?
The immediate mission. Rapid differentiation. We've got to quickly sort out if this is vasospastic angina or a more conventional ACS, a STEMI or the STEMI, driven by plaque rupture. So the initial evaluation really needs two things happening simultaneously. First, you need an ECG, crucially, captured during symptoms. Now, that's often the biggest challenge because these episodes can be so brief.
Right, they might resolve by the time you get the leads on.
Exactly. And second, you need to get cardiac troponin levels checked right away. This helps us understand if the spasm, even if it was short, caused actual myocardial injury.
Okay, so we've done that initial screen. Let's say the suspicion for Prinzmetals is still high. How do we actually nail down the diagnosis? I know there's a specific sort of triad of criteria.
Yes, there's a diagnostic triad, and all three parts really need to be met for a definitive diagnosis. Pillar number one is the clinical picture itself. We're looking for angina, chest pain that responds to nitrates. But here's the key. It's distinctly not related to physical exertion. It happens at rest.
Usually at rest.
Yes, typically at rest. And often there's this really marked diurnal variation. Patients might report it happening nocturnally or in clusters in the early morning hours, often waking them up. The pain itself, usually retrosternal, pressure-like. It can really mimic typical angina, which, adds to the confusion initially.
That diurnal pattern is fascinating, isn't it? Often tied to changes in autonomic tone, right? So what about the second part of the triad, the electrical signature on the ECG? What has to show up there?
Right, because the spasm causes such profound, often transmural ischemia. The ECG changes are quite specific, but also transient. That's the key word again, transient. We're looking primarily for ST segment elevation, usually at least 0.1 millivolts, in two or more contiguous leads. This reflects that acute, temporary transmural injury pattern.
Like a STEMI, but one that comes and goes.
Exactly. But it's important to remember it's not just ST elevation. Transient ST depression or even new negative U waves in the right leads can also satisfy this criterion. But the classic hallmark is that ST elevation that just melts away when the spasm stops or nitrates are given.
Okay, clinical picture, transient ECG changes. What's the third pillar? This usually involves getting a closer look at the arteries themselves, doesn't it?
It does. The third pillar is the objective proof of the coronary artery spasm itself. This generally requires cardiac catheterization. What we need to see, angiographically, is that transient severe narrowing, usually defined as more than 90% constriction of a major coronary artery. And crucially, this narrowing has to line up perfectly in time with the patient's symptoms and those ischemic ECG changes we just talked about.
And you might just get lucky and see it happen spontaneously during the CAHOS.
You might, if the patient has an episode right then and there. But more often, if the diagnosis isn't clear from spontaneous events, we rely on provocative testing during the procedure to induce the spasm safely. We get into that a bit later.
You mentioned earlier we need to shift our mindset. This really gets to the core difference between Prinzmetals and standard angina, the kind caused by fixed blockages. Standard angina is about demand, right? The heart needs more oxygen than the narrowed pipe can deliver.
Precisely. Standard angina is a demand-side problem. Prinzmetals flips that entirely. It's the ultimate supply-side issue. The heart's oxygen demand could be minimal. The patient might be asleep, but the supply is suddenly drastically cut off by that intense vasoconstriction.
And the state of the coronary arteries themselves, whether they have underlying disease or not, that matters a lot too, doesn't it?
Hugely.
Yeah.
It has major prognostic implications. This spasm, it can happen in arteries that look perfectly smooth and normal on an angiogram. It can also occur in vessels with mild non-obstructive disease. But, and this is critical, it can also happen in arteries that already have significant fixed blockages, obstructive coronary artery disease. The guidelines are very clear. When you have both vasospasm and obstructive CAD, the prognosis is significantly worse. The risk of major adverse events goes way up.
Which is another big reason why getting that angiogram is so important early on to see what landscape the spasm is happening in.
Exactly. You need to know the baseline anatomy.
Okay, that paints a really clear clinical picture. Now, to understand why we treat it so differently, especially those medication contraindications we'll get to, we need to dig into the why behind it all, the pathophysiology, this vascular hyperreactivity.
Right. The fundamental mechanism is that transient, really intense squeezing vasospasm of a major epicardial coronary artery. That leads directly to the transmural ischemia we see. But what's driving that intense squeeze? It's basically hyperreactivity and over-responsiveness of the smooth muscle cells in the coronary artery wall. And the reason why they're so hyperreactive often points towards a more systemic issue.
And that issue often starts right at the inner lining of the blood vessel itself, endothelial dysfunction.
Precisely. Endothelial dysfunction seems to be a key player here. In a healthy artery, the endothelium, that inner lining, releases nitric oxide. Nitric oxide is a really potent vasodilator. It tells the smooth muscle to relax. In patients prone to Prinzmetals, this nitric oxide system isn't working properly. The vessels don't dilate as they should. At the same time, there seems to be an increased release or sensitivity to substances that cause constriction, powerful vasoconstrictors like endothelin or serotonin.
So the balance is off, less relaxation, more constriction signals.
Exactly. It creates this environment where the vessel is just primed to spasm.
And thinking about risk factors, there's one major one that directly ties into messing up that nitric oxide pathway, right?
Smoking,
Yeah.
without a doubt. Tobacco use is the single most prominent, most well-established risk factor for Prinzmetal's angina. The toxins in cigarette smoke directly injure the endothelium, they promote oxidative stress, and they specifically interfere with nitric oxide production and availability. It just hammers that delicate balance.
So when we talk about treatment later, quitting smoking isn't just a good idea, it's absolutely central to managing this condition.
It's paramount. Honestly,
Yeah.
the effectiveness of our medications is significantly blunted if the patient continues to smoke. It's probably the single most critical intervention we can push for.
Beyond smoking, are there other typical features? Does the patient profile differ from someone with standard atherosclerosis?
It often does, yeah. While typical atherosclerosis risk increases steadily with age, Prinzmetal's tends to show up in a somewhat younger group. Not always, but often. There's also some data suggesting it might be a bit more common in women, although men certainly get it too. But perhaps one of the most interesting links, pointing again to that systemic vascular issue, is the association with other vasospastic conditions. It's not uncommon for these patients to also have Raynaud's phenomenon, where the fingers blanch in the cold, or migraine headaches.
So it suggests a sort of generalized tendency for blood vessels to overreact, not just in the heart?
Exactly. It strengthens the idea that this isn't just a localized coronary problem, but maybe a systemic vascular hyperreactivity disorder that's manifesting most dangerously in the heart arteries.
Okay, that makes sense. Now let's think about the inpatient setting. What are some acute triggers we need to be aware of, things we might inadvertently do, or things the patient might be exposed to? Medication reconciliation must be key here.
Oh, absolutely. Meticulous medication review is crucial because there are definitely triggers that can push someone into an acute spasm. Some are physiologic things like significant emotional stress, exposure to intense cold, which ramps up the sympathetic nervous system, or even hypoventilation can sometimes provoke an episode. But from a medication standpoint, we have to be incredibly careful about anything that might tip that balance further towards vasoconstriction.
Which drug classes are the main offenders we need to watch out for?
Well, anything acting on the serotonin or sympathetic systems needs close scrutiny. So serotonergic agents are a big one. This includes common migraine drugs, the triptans.
Like sumatriptan.
Exactly, and potentially even some SSRIs, the antidepressants, especially maybe at higher doses or in combination with other agents. We need to be mindful. Then there are ergot derivatives, sometimes used for difficult headaches. And definitely all sympathomimetics that includes things like pseudoephedrine and over-the-counter cold meds, and critically illicit drugs like cocaine. Cocaine is a notorious trigger for severe, sometimes fatal, coronary spasm.
Wow, so really understanding everything the patient is taking, prescribed or not, is vital right at admission.
Absolutely vital.
And just briefly, before we move to diagnostics, The sources also mention inflammation playing a role?
That's right. There's growing evidence suggesting that systemic inflammation and oxidative stress kind of feed into that endothelial dysfunction, making the vessels more prone to spasm. It's likely part of the broader picture. And it's also clear that other health problems matter a lot for outcomes. Things like older age, having heart failure, or chronic conditions like kidney or liver disease. These are all independent flags for higher risk of dying in the hospital if you have Prinzmetals. It really underscores that this can be a marker of overall fragile vascular health.
Okay, let's shift gears to the inpatient diagnostic strategy now, going beyond that initial triage. We already mentioned coronary angiography is important to rule out fixed blockages. Can we elaborate on its role here?
Sure. Coronary angiography plays several critical roles. As we said, first and foremost, it tells us definitively if there's significant obstructive CAD. Finding that changes the prognosis, potentially changes management too. Maybe you need revascularization for the fixed lesion in addition to treating the spasm. But the unique role of cath in suspected Prinzmetals is to confirm the spasm and its reversibility. Ideally, you see that intense temporary narrowing in the artery, and then crucially, you administer intracoronary nitroglycerin and you document that the narrowing completely resolves. That complete resolution after NTG is the gold standard proof of vasospasm.
And what if you don't see spontaneous spasm, but you still strongly suspect it? You mentioned provocative testing. What about cases that aren't classic epicardial spasm?
Right. So if spontaneous spasm isn't caught, provocative testing with agents like acetylcholine or ergonovine can be done during the cath to try and induce it under controlled conditions. And for more ambiguous cases, or where you suspect the problem might be in the smaller vessels, sometimes more specialized invasive coronary function testing is needed. This involves measuring things like coronary flow reserve and microvascular resistance to differentiate between spasm in the big epicardial arteries, classic Prinzmetals, versus spasm in the tiny microvessels. The treatment might be similar, but understanding the exact location helps refine the diagnosis.
Let's circle back to cardiac biomarkers for a second. Troponin. We said it helps gauge injury. If the spasm is brief, troponin might be normal. What does it really signify if the troponin is elevated? How does that change things?
An elevated troponin here is a big deal. It's a major red flag. While brief, resolved spasm often leaves troponin normal, an elevated level tells you the spasm was severe enough or lasted long enough to cause actual heart muscle death, a myocardial infarction due to vasospasm. This definitely changes the picture. It implies a more severe underlying hyperreactivity, maybe less responsive vessels. It ramps up the concern for complications, especially arrhythmias, and usually means more intensive monitoring and likely a longer hospital stay to ensure stability.
Okay, that makes sense. Now let's talk about what might be the single most important aspect of inpatient care here: continuous ECG monitoring. Why is the AHA so specific about needing continuous ST segment monitoring?
It boils down to the nature of the beast. It's transient and it's high risk. Those ischemic ECG changes, the ST elevation or depression, they can be incredibly fleeting. A single static 12-lead ECG, even if done frequently, is very likely to miss the actual event.
You might just get lucky, but you probably won't.
Just exactly. Continuous ST segment monitoring provides that real-time beat-to-beat surveillance. It allows us to catch the ischemia the moment it happens, whether the patient feels it or not. And critically, we know a large proportion, maybe up to 70%, of these ischemic episodes can be silent, especially during sleep. But silent ischemia carries the same dangerous potential for arrhythmias as painful ischemia.
And that leads directly to the electrical risk, doesn't it? We're not just watching for ST changes mimicking a STEMI. We're on high alert for arrhythmias that can cause cardiac arrest.
Absolutely. That's the paramount concern. Continuous monitoring is essential because these life-threatening arrhythmias often happen right at the peak of the vasospastic episode. When that vessel clamps down hard, the resulting severe ischemia creates massive electrical instability in the heart muscle. So we're looking for the really dangerous ones: polymorphic VTAC, VFib, sudden high-degree AV block, even asystole. These are the arrhythmias that cause syncope or sudden cardiac death in Prinzmetal's patients. Having them on the monitor means we see it instantly and can intervene to defibrillate, pace, whatever's needed. Without the monitor, the first sign might be a code blue.
So given how dynamic this is, if a patient does report symptoms like chest pain returning, even if the bedside monitor looks okay at that exact second, we need a 12-lead stat, right?
Immediately, yes. Any recurrence of symptoms demands a prompt 12-lead ECG. And if the situation is very acute, maybe the initial ECGs were unclear, standard practice is to get serial 12 leads frequently, say, every 15 to 30 minutes until you either capture the dynamic changes or the patient is clearly stabilizing.
Okay. And one last point on diagnosis, that provocative testing in the cath lab. If we need to do it using ergonovine or acetylcholine, what are the safety considerations? It sounds potentially risky.
It is potentially risky and requires extreme caution. It should only be done in a controlled cath lab setting by experienced operators. You need to be fully prepared to reverse the spasm instantly. That means having intracoronary nitroglycerin drawn up and ready to inject the second you see significant induced spasm or the patient develops symptoms or dangerous ECG changes.
Guide wire in place.
Absolutely. Guide wire down the vessel often, resuscitation equipment right there, because if you induce a spasm and can't reverse it quickly, you could precipitate a prolonged ischemic event, an acute MI, or those malignant arrhythmias right there on the table. It's effective for diagnosis when needed, but it demands respect and preparation.
That really highlights the seriousness. Okay, let's transition fully into management now. Starting with an acute episode, the patient is having chest pain, the ECG shows those transient changes. What's the first-line treatment?
Acute management is generally very effective, thankfully. And it really hinges on one main drug, rapid-acting nitroglycerin, NTG. It's the go-to first-line therapy. Why? Because it's a direct, powerful vasodilator. It works immediately to relax that spasming coronary artery, smooth muscle, restore blood flow, and relieve the symptoms.
And how do we typically give it in the hospital setting? Sublingual first?
Yes, start with sublingual NTG for rapid relief. That's usually sufficient. Intravenous NTG is generally reserved for situations where the symptoms are persistent despite sublingual, or if the spasm is causing significant complications like acute heart failure or maybe severe hypertension along with it.
And while we're giving NTG, we're obviously keeping a close eye on the monitor for arrhythmias. What about other supportive measures? Oxygen, morphine.
Right, arrhythmia surveillance is ongoing. As for adjuncts, supplemental oxygen isn't routine unless the patient is actually hypoxic, O2 saturation below 90%, or if they're showing signs of respiratory distress. Otherwise, it's not clearly beneficial. Morphine can be considered if the pain isn't fully relieved by NTG, but the real priority is reversing the spasm with nitrates. Pain relief follows flow restoration.
Okay, that covers the acute event. Now, crucially, maintenance therapy. How do we prevent these episodes from recurring? What's the cornerstone of long-term treatment?
The absolute cornerstone of maintenance therapy is calcium channel blockers, CCBs. These are the first-line agents, used either alone or sometimes combined with long-acting nitrates. Their goal is to suppress the spasms, reduce the frequency, reduce the severity. The mechanism is straightforward. CCBs block the entry of calcium into those coronary smooth muscle cells. Calcium influx is what triggers contraction, so by blocking it, you inhibit that intense squeezing, that spasm.
When we're choosing a CCB, does it matter if we use a dihydropyridine type, like amlodipine, versus a non-dihydropyridine, like diltiazem or verapamil?
That's a great question. Both classes are considered effective for preventing coronary spasm. The choice often depends on the individual patient's characteristics, mainly their baseline heart rate and blood pressure. Non-dihydropyridines, diltiazem, and verapamil are often excellent choices because they provide strong coronary vasodilation, plus they have a rate-slowing effect, which can be beneficial. However, if the patient already has a slow heart rate or maybe significant systolic heart dysfunction, then a dihydropyridine like amlodipine or nifedipine, long-acting form, might be preferred because they are potent vasodilators with less impact on heart rate or contractility.
So tailor it to the patient. And the goal is usually pretty aggressive dosing, right?
Yes, the goal is generally to push the dose of the CCB to the maximum tolerated level, or sometimes even use combination CCV therapy to achieve complete or near-complete suppression of symptoms and ischemic events.
You mentioned nitrates as well. How do long-acting nitrates fit into the maintenance plan?
Long-acting nitrates, like isosorbide mononitrate or denitrate, are often used as adjunct therapy, especially if CCBs alone aren't fully effective, or if the patient has predominantly nocturnal symptoms. They provide a continuous background level of nitric oxide-mediated vasodilation, which helps keep the vessels relaxed and seems to work synergistically with the CCBs to prevent spasm.
Okay. And what about statins? We usually think of them for cholesterol, but they have a role here too, related back to that endothelial dysfunction.
Exactly. Statins are recommended not just if the patient has underlying atherosclerosis, but often even in isolated vasospasm. This is because of their pleiotropic effects beyond lipid lowering. Statins have been shown to improve endothelial function. They can increase nitric oxide availability, reduce inflammation and oxidative stress in the vessel wall. So they essentially help heal that dysfunctional endothelium and make the vessel less prone to spasm. It's an important part of long-term vascular health strategy here.
What if someone is still having frequent episodes despite being on maximal doses of CCBs and nitrates? Are there other options for these refractory cases?
Yes, for those truly refractory cases, there are a few other things we can consider. Magnesium supplementation has some evidence, as magnesium acts as a natural, smooth muscle relaxant. Some sources mention alpha receptor blockers, aiming to counteract any sympathetic-driven vasoconstriction, although that's less common. Ranolazine, a drug sometimes used for chronic angina, is also cited as a potential option for persistent symptoms in Prinzmetals. But really, the first step in refractory cases is ensuring maximum tolerated doses of the first-line agents, the CCBs and nitrates, are truly being used, perhaps even combining different types of CCBs before moving to these other options.
Okay. Now, we absolutely have to talk about the contraindications. This is probably one of the most critical teaching points for managing Prinzmetals inpatient. What medication class must be absolutely avoided?
Beta blockers. This is a hard and fast rule. Beta blockers are contraindicated in patients with known or strongly suspected Prinzmetal's variant angina.
And why is that? What's the mechanism that makes them so dangerous here?
It comes down to the receptors on the coronary arteries. These arteries have both alpha-1 adrenergic receptors, which cause vasoconstriction when stimulated, and beta-2 adrenergic receptors, which cause vasodilation. If you give a beta blocker, especially a non-selective one, you block the beta-2 mediated vasodilation. This leaves the alpha-1 mediated vasoconstriction unopposed, so any sympathetic signal tells the vessel only to constrict, potentially leading to severe, unopposed coronary vasospasm. It can dramatically worsen the situation.
Unopposed alpha constriction, that's the key phrase to remember. Are there other common cardiac meds we need to be cautious with? What about aspirin? NSAIDs?
Good points. Aspirin is a bit nuanced. While low-dose aspirin might be used if there's coexisting significant obstructive CAD, high-dose aspirin should generally be avoided. The concern is that high doses might inhibit prostacyclin, which is a vasodilator, and could theoretically worsen spasm. Most non-steroidal anti-inflammatory drugs, NSAIDs, should also generally be avoided in the context of any acute coronary syndrome, including this one, unless there's a very compelling reason.
And short-acting calcium channel blockers.
Right, specifically short-acting dihydropyridines, like immediate-release nifedipine. Those should be avoided because they can cause a rapid drop in blood pressure, leading to reflex tachycardia, which could potentially increase myocardial oxygen demand and worsen ischemia. Long-acting formulations are preferred for maintenance.
And the standard warning. Nitrates are a no-go if the patient recently used phosphodiesterase inhibitors for erectile dysfunction due to the risk of profound hypotension.
Absolutely. That interaction is critical to screen for.
Okay, let's talk about complications. We know the spasm causes ischemia. We mentioned acute MI as a risk if it's prolonged, but let's reemphasize that immediate life-threatening electrical risks.
Yes, the electrical instability is truly the most feared complication. Those malignant arrhythmias we keep mentioning, polymorphic VTAG, VFib, high-degree AV block leading to asystole, these are direct consequences of the severe ischemia during the spasm itself. They are the primary mechanisms behind syncope and sudden cardiac death in these patients. The risk is highest right during the acute ischemic episode.
And MI can happen even without fixed blockages, just from prolonged flow interruption.
Correct. Severe, prolonged spasm can definitely cause myocardial infarction, even in angiographically normal arteries. And unfortunately, recurrent MIs can occur if the condition isn't well controlled with maintenance therapy. It really hammers home the need for effective suppression of the spasms.
We talked about the importance of continuous monitoring initially. How do we decide when it's safe to take the patient off the monitor? That's always a big question on the wards.
It is a critical decision. Continuous monitoring is essential acutely, but obviously can't go on forever. The guidelines suggest reassessing the need for it at least every 24 hours. The key criteria for safely discontinue continuous monitoring are clinical stability. This means the patient needs to be completely free of symptoms, have no recurrent ischemia detected on the monitor, no more ST changes, and crucially, have had no significant arrhythmias observed. You need to be confident that the maintenance medications are effectively suppressing the vasospastic events before stepping down that level of intensive monitoring.
But for some higher-risk patients, maybe there's an intermediate step before they leave the hospital entirely.
Yes, for certain patients considered higher risk, Maybe those who presented with syncope had documented dangerous arrhythmias during their stay, or perhaps there's still concern about silent ischemia despite treatment using ambulatory ECG monitoring, like a Holter monitor or an event recorder, for a period before discharge can be really valuable. It gives you a snapshot of what's happening electrically outside the constant vigilance of the telemetry unit, helps quantify any remaining ischemic or arrhythmic burden, and really aids in final risk stratification before they go home.
That makes a lot of sense. Okay, let's wrap up by talking about prognosis and discharge planning. What's the general long-term outlook for someone diagnosed with Prinzmetals?
With accurate diagnosis and good adherence to appropriate medical therapy, the overall prognosis is actually generally favorable, especially if there's no significant underlying obstructive coronary artery disease, just the vasospasm. Long-term survival can be quite good, and the condition can often be very well managed, sometimes even seems to go into remission over time.
But as we discussed, certain factors definitely predict a worse outcome.
They do. We need to identify those predictors early. The big ones are the presence of coexisting obstructive CAD that significantly worsens the outlook. Older age is a risk factor. And having those other major comorbidities like heart failure, chronic kidney disease, or liver disease also points to higher mortality. And of course, patients who've already had documented malignant arrhythmias or survived a sudden cardiac death event related to spasm are in a particularly high-risk category. They need the most aggressive management and potentially consideration for an ICD if spasm control isn't perfect.
So given how much depends on ongoing management, discharge education must be incredibly thorough.
Absolutely critical. Patient education is key for long-term success. It has to cover medication adherence, why they must take their CCBs and nitrates consistently, and why they must avoid beta blockers. But perhaps even more important is hammering home the risk factor modification piece, starting that conversation in patient. Strict avoidance of known triggers is vital. And number one on that list, the single most impactful intervention, is complete and permanent smoking cessation. You just can't effectively manage this long-term if the patient continues to smoke.
It really comes back to that underlying endothelial health, doesn't it? Minimize the triggers, heal the vessel lining. Well, this has been incredibly informative. We've covered the diagnosis, the absolute necessity of that continuous monitoring for electrical risk, the specific pharmacologic approaches, and those critical contraindications.
Which leads us, I think, to a final thought, something for our listeners to consider as they manage these patients after they leave the hospital safety net. Given how transient Prinzmetal's angina can be, and knowing its strong link to potentially silent but deadly arrhythmias even when patients seem stable and symptom-free on their meds, how can we perhaps better utilize things like advanced ambulatory monitoring after discharge? How do we effectively risk stratify and protect those individuals who might still be vulnerable to sudden cardiac death even when they're seemingly doing well outside the hospital?
That's a powerful question. It really captures that ongoing challenge, balancing clinical stability with ensuring electrical safety long-term in this unique patient group. A really comprehensive deep dive today into inpatient management of Prinzmetal's variant angina.